As is the custom, I'll introduce the team by the name of the client organization only. And this is the Grady Health System.
Well, good afternoon. I'm John Hoppert, President and CEO of the Grady Health System in Atlanta, Georgia. It is an amazing honor for Grady Health System to be a finalist for this most prestigious award. Today, we want to share with you an amazing transformation that began in 2008, and it continues on today in the emergency department at Grady Memorial Hospital. A transformation has become a national best practice of how a healthcare institution can utilize a systems approach to transform workflows as well as patient care. But first, let me share with you a quick video to introduce you to Grady.
This is the place where people come when they're hurt, or are sick, or want to be born, or want to learn how to help people be born. Because it's also the place that trains 25% of the medical doctors working in Georgia today. That's a lot of doctors, but we think you're worth it. Back to the place. It's a place where you'll find the most advanced medical technologies on the planet, like the Marcus Stroke and Neuroscience Center, recognized around the globe for its advanced stroke treatments, or Georgia's first cancer center for excellence, including the Avon Foundation Comprehensive Breast Center. Want more? How about the first comprehensive sickle cell center in the world? The only burn center in the state that treats both adults and children. A robotic pharmacy. You heard me right. Robotic pharmacy. Teen Health Center? Check. Poison Center? Check. Trauma Center? Check, check, check. This place also handles all disaster coordination and serves as Atlanta's 911 ambulance provider. We even have special ambulances called the Angel 2 for those teeny tiny babies who just can't wait to be born. And if you're in an even bigger hurry to get to this place, there's a helipad. Nice ride. Back to the place. A place that's not just remarkable because I say so, but because others do too. And not just any others. Others who recognize advances in areas such as the treatment of strokes and brain injuries and teeny tiny babies. Which doesn't mean it's just the best place for trauma and stroke and teeny tiny babies, which it is. It's really the best place for everyone. And that's exactly what Henry W. Grady intended it to be when he first conceived this place about 120 years ago. And that's something special.
The emergency department at Grady Memorial Hospital really is the front door to the hospital. The emergency department provides 125,000 patient visits per year. 75% of the admissions to the hospital come through the emergency department. In addition, Grady has seen a 300% increase in the last 3 years in mental health visits to the emergency department, and we continue to see emergency visits increase due to the fact that primary care physicians are referring their patients to emergency departments after hours. In 2008, Grady was experiencing rapidly growing ED volumes, along with extended wait times, extended average length of stay, and every performance indicator that we look at to evaluate emergency department efficiency was headed in the wrong direction. So, what to do? Grady established a relationship with Dr. Eva Lee and her team at the Center for Operations Research in Medicine and Healthcare at Georgia Tech to create patient flow and care models in the emergency department that would improve both the efficiency and effectiveness of care provided in the ED. We are excited that our work has made Grady the first public hospital to be named a finalist for the highly coveted Informs Edelman Award. Our stated vision is to become the nation's leading public academic healthcare system. Your acknowledgement of our emergency department transformation is a clear signal that we are on the right path to realizing that vision. Now let me introduce to you Dr. Hanny Atola, Chief of Emergency Medicine at Grady, and Assistant Professor at the Emory School of Medicine. Hanny?
Thank you, Mr. Hopert. So emergency department challenges aren't unique to Grady Health System. ED volumes between 1996 and 2006 across the nation have increased by 32% and are projected to double between 2000 and 2020. About 27% of hospitals closed between 1990 and 2009 in non-rural areas. ED visits account 35% of ED visits are made to trauma centers like Grady Memorial Hospital, and 34% of ED visits are semi-urgent and non-urgent conditions that could be treated elsewhere. Couple that with aging U.S. population, long length of stay and wait times, and shrinking rates of reimbursement, and America's emergency care environment was given a D+ grade by the American College of Emergency Physicians in a recent report. Challenges unique to Grady are in 2007, due to the financial environment that we had, Grady nearly had to close its doors. Only 8% of our patients were privately insured, 36% had Medicaid or Medicare, and 55% were self-pay or had no insurance. This is compared to the national insurance rate of about 50%. We are a level 1 trauma center with over 120,000 ED visits per year and are vital to the city of Atlanta. Long length of stay, high number of patients who left without ever seeing a doctor, and opportunity for improved quality of care were all challenges that we encountered. As you can see, the volume between 2011 and 2013 has continued to increase, and in 2013 we saw just over 125,000 patient visits to our emergency department. The patients, when they arrive to the emergency department, are assigned acuity score. So it's called the Emergency Severity Index. A level 1 is patients who need to be seen immediately. These are patients who are having acute strokes, heart attacks, or who are victims of trauma. At the other end of the spectrum are the level 5 patients who come for conditions such as coughs, colds, and minor injuries. At Grady in the emergency department, there are 5 main treatment areas. There's the blue zone, which is our major medical area where we treat heart attacks, strokes, and patients with overwhelming infection. The red zone, where we treat our moderate to low acuity patients, including our mental health patients. We have our PACE or fast track area, which treats the lowest acuity patients that we have. We have a detention treatment area as well, which treats patients from the federal prison as well as county and city. And in addition, we have a trauma treatment area, which is where we treat our trauma patients. So a few definitions. The length of stay in the emergency department is from when a patient arrives to the emergency department to when he or she leaves the emergency department. So for admitted patients, those are patients, the length of stay ends when the patient departs to their inpatient bed. For patients who are discharged from the emergency department, those patients, when they physically leave the emergency department, that is when the clock stops for their length of stay. An avoidable revisit is a revisit resulting from an adverse event that occurred during the initial visit or from inappropriate care coordination following discharge. This is a major burden to the U.S. health system and accounted for $20 billion in Medicare spending in 2005 and is increasingly not being reimbursed by insurers. Left without being seen are patients who arrive to the emergency department but left before they could be seen by a qualified medical provider or physician. So this is a simulation. On the left side of the screen, you'll see a layout of our emergency department. To the very bottom left, you'll see our fast track area. And this is the red zone right in here, blue zone, and the Marcus Trauma Center up at the top. More importantly, in the middle of the screen, you'll see a long line. That's our waiting room line. Ideally, a waiting room would be empty. But because of inefficiencies in the system, we were never able to completely empty out our waiting room. And therefore, we had patients who were always waiting to be seen. A best practice is for patients to be immediately bedded when they come to the emergency department. In 2008, we had high volume, average length of stay of approximately 14 hours, a high volume of patients who left without being seen, high cost to the health system due to inefficiencies in short stay admissions, and high ED costs due to no place to redirect some of our lower acuity patients. So our objectives were clear. We needed to improve the timeliness, quality, and efficiency of care using our existing resources. Our goal was to reduce our length of stay by 50% to 7 hours, reduce wait time to see a qualified medical provider, to reduce left without being seen, and to reduce revisits by 20%, and understand care characteristics to allocate resources appropriately. I'd like to introduce my colleague, Dr. Eva Lee from Georgia Tech.
Thank you. Here, I would like to show you the systems approach. On the far left, you will see the patients, the hospitals, and also the providers. Their characteristics of the disease and also the resource and the process itself. I also want to point out that we model those in and out process in the ED because those are the dependency processes in which that shows the bottleneck of the hospital as well as the ED itself. With the data that we look at, it includes the electronic medical record data that include all the disease as well as the treatment itself. There are historical data from the hospital as well as the operations, basically the hospital, how they actually operate and how busy all these different components are. We also have time motion study where we take measurements of the service and the operations itself. Armed with all these data, that is a big data framework, and everything is big, and the hospital clearly has lots of data. Then we actually use the machine learning approach to analyze the disease as well as the treatment characteristics. We also use all the data collected to build the interdependency of all these processes, from the ED all the way to units that are being connected to the surface of the ED. Then we input all these data into the simulator and optimization system. So if we look at the study itself, is that one of the key part is that when the doctors ask us to look at it, is that they not only want efficiency of the processes, they keep telling me that they need quality also. Because Grady is well known in terms of the quality of care, and they have to treat really severely patient from the trauma care. So they ask us, don't sacrifice the efficiency, like the quality, just because we want efficiency. So that's the part that we do, is we coupled all these operations as well as the disease trend as well as the treatment characteristic itself into a single model. We also model the interdependency so that we understand the bottleneck in the ED is not just the ED itself. For example, a patient that is to be discharged into the ICU cannot be moved to the ICU when there's no bed. And they hold up the place in the ED, and that is truly a bottleneck. So this is not like something that we can say, okay, let's model ED and do it really well, and then the patient has nowhere to go. So this is a true bottleneck that we have to model. There's also the exciting part, and I think we are not alone, is that because of the Affordable Care Act, there is the penalty imposed on revisit. There's also the issues that this revisit will not be paid for anymore. So Affordable Care Act basically drive all these incentives of a hospital to do that. But Grady started earlier because Grady understand that they cannot waste the resource to treat the revisit patient. They need to do it really well so that patients do not have to come back. So we model this using all the data that is available, and then have all these information into one system and then trying to really optimize the entire system. So the goal, of course, is that the doctors always like to see, is it truly an optimal system, or is it we strive for the best solution that will come out from the system? So to give you an idea, this is the machine learning system that we have. It is a discrete support vector machine. For those of you that are in optimization, you realize that the system, such type of system, is very dense matrix. And so the idea is that for every single patient is associated to a 0-1 integer variable. And the attributes include all the patient characteristics, the treatment characteristics, as well as the process itself, how they are being treated. And going through the system, two key things that come out from it is the prediction, if this patient will come back or not. So we want to catch this patient. And secondly, the characteristics of the treatment and the disease itself. This is extraordinarily important because that allows you to allocate resources appropriate to those patients that really needs them. So the system itself is an interesting part in terms of the mathematics, and of course, doctors always like to know how does that things come out. Of course, everything comes out from the computer, but there's some uniqueness in this system is that this is a multi-group classification, and that it actually allows you to actually do multi-stage analysis. That means not only you classify them in the first stage, is that you can put some of these patients in the reserve judgment and classify them successively when you get more results, and the knowledge itself built onto the machine learning one. And this is the first time that all these properties are built into a single model. From the theoretical point of view, this problem is NP-hard, and that you can show that the classifier is universally strongly consistent. So these are very nice property. NP-hard, of course, we all know that it is difficult to solve. The idea is that we would like a model that can handle imbalanced data. Why is that so important? Revisit patient constitute only 5% of the hospital ED visit. then it is very important for us to be able to predict these patients just as well as predicting those that do not return. So that's why that property is important. Then looking at the simulation itself is that we want a simulator that is fast, and I think all of us would appreciate it because this is for operational as well as strategic decision. We also design the optimizer that do resource allocation. Here the decision variables are how do you assign resource to each of the service units in the ED. Resources include human, include beds, include the rooms and the equipment. Everything has to come together. And then we optimize the system. Mathematically, if we look at the first part, the first two constraints, basically it sets allocating the resource to different units based on the skills and all the needs that those units required. Then after the first round optimization, then you do a simulation. You look at the performance of the system and take in those simulation data, and that incorporates into the constraint set 3 and 4. And that you see that using those information, you optimize again, this time penalizing those service block that has too long of a time. So clearly, we want everything fast, and I think it is easy for operations researcher to understand it because you want to be able to look at results. You want to be able to see what is going on to the system and what are the bottlenecks. And now next I'm going to show you how it is incorporating the machine learning part in it. So the input data includes the patient information and also the process itself. So for the Grady process, it includes about 200 processes, both the ED process as well as everything that depends and also interconnected to it. And also you can read in the floor plan, basically it's the blueprint of the ED. Then that is the first part of the input. The second part of the input are the automated data coming out from the machine learning data, and that feeds into the back end. In the back end, several mathematical models are generated. One is the discrete event simulation to model the process. One is the agent-based model that model the disease as well as the treatment characteristics, and then the optimization system. The optimization and the simulator loop through together in the red box here. And then before we report the results out to the leaders, then we do the optimization and simulation one more round to get all the statistics. So I'm not able to put all the little boxes inside the one slide, and this is pretty busy, but I'm going to do like a little dry run between the optimization and the simulation, how it works. Initially, we optimize the resource of all these human equipment and bed across the ED. Then we simulate the process, getting the flow time, waiting time, and queue length. Now we look at the flow time. The flow time of our simulation system corresponds to the length of stay of the individuals. And as Dr. Atala has mentioned, they really want it to be 7 hours. So that is really what they want. So we put in that and see how much violation is that to the 7 hours. Then looking at the longest wait time units, we put a penalty on those service blocks, and then we optimize. So we loop through these loops several times until we get a solution that is close to the 7 hours. Then now we look at the statistics of the performance. We look at the queue length and wait time and all of these and see if it actually fit into the desired values that the doctors want. Doctors always know what they want in a sense that they always tell you, give me this. But the idea is that how much can you give them that is as close to what they desire, right? So that's really important. Then the output itself will be returned to the doctors and the leaders to look at it. So two of the things that I would like to mention is the following. First, it is really important for us to see that this is not, the solution that come out from the system is not a proven optimal solution because there is no closed form for this problem. So we appreciate the difficulty and we try to aim at getting the solution as good as possible so that the doctors can look at what type of improvement do we see. Second, anyone could take their favorite simulator and the favorite optimizer and build a system like that. And in fact, a lot of the commercial systems are trying to build a system like this so that it has a seamless incorporation of simulation as well as optimization. The trick here is how can we provide such a product so that someone outside OR can actually use it and that they don't need to worry about the back-end complexity and all the simulation and optimization. They don't have to really try to fix it and make it work. And I think that is really important. So we work really hard to get that part because I have to say that the leaders really like to play with it. In fact, the first time, like when I show them the results, the senior vice president asked me, can I play with it? And I said, yes, you have to. And I think that is really nice. So how does the method work all together, putting the machine learning as well as the simulation and optimization together? So we got the patient, the providers, and the hospitals. And we got all the data from the hospital as well as the collected data that we get. Then the machine learning system takes in all this data, and as I mentioned, two really important parts that we come out with the machine learning system is the disease characteristics as well as the treatment profile and how that actually collaborate with each other. Then also a predictive rule. Next, simulation of the process itself. I make a very simple diagram here, so that's the flow process. And then the simulation of the disease and the treatment corresponding to that using the information from the machine learning. Now, once the patient gets treated, they go through the system, then there is the little sticker there saying, okay, should we have this patient observed or not? Remember, we want to catch those patients that may come back. And this is done by using the predictive rule that comes out from the machine learning tool and then advise the system that this patient should be sent to the clinical decision unit to be observed before they actually are being discharged to different units in the hospital or being discharged home. We use 6 months of data to fine-tune the model to, that consists of about 45,000 patients, and trying to really fine-tune all the parameters so that it feeds into the statistics that is obtained and given to us by the hospital. Then next, we use 3 months of independent data, trying to see how well it actually predicts this information, and working really hard on that. By then, everybody in the hospital know us, and they are really anxious to see the result and to see whether it's good or not. And so we got between about 2 to 5% accuracy, which is really very nice data that we have. Next, then we optimize the whole systems and provide some recommendations to the senior leaders. As I mentioned that at that time, everybody is expecting us to give them recommendations because they know that we are there for a long time, and knowing that we also have recommendations. So they would like to know how do they prioritize all these recommendations so that they can successively implement them. One of the key part is really documentation. As Dr. Atala mentioned, is that change is really something you have to do in the ED because there is so much demand, and it is true not just at Grady, it is true in many EDs. So it is very important for us to actually document the change and see what improvement do we see.
Thank you, Dr. Lee. So the change and the sustainability were two very important parts for our emergency department to make sure that it worked. We had buy-in from the hospital administration all the way from the senior VP of operations to the staff in the emergency department. We knew that we needed this to survive, and we knew that we needed this for the hospital as well as for our patients. We had a very strong desire to improve. We had financial challenges such as reduced reimbursement and increased penalties that continue to be challenges today, and we knew that this extended beyond the emergency department. We have a saying that the only constant we have is that we're constantly changing. And this was very true in this project as well. So the challenge that we had was the sustainability. With the high volume of patients, the moving bottleneck throughout the emergency department, we needed to make sure that we could maintain the change. So implementation, phase 1, started in 2009, and it was when we optimized staffing, we reduced some of the bottlenecks, we reduced the movement of patients and batching of patients throughout the emergency department as well. In 2010, for 4 months, we added the clinical decision unit, which is our short stay unit, to reduce hospital readmissions. And in this time period, hospital administration was trying to raise funds to be able to to further the improvements we had started. During phase 2, after the addition of the Marcus Trauma Center and the clinical decision unit, we had to re-optimize the whole process. The shaded boxes that you see didn't cost the hospital system any additional funds. And then currently we are undergoing a major ED renovation and expansion where the goal is to improve the flow throughout the department and make it easier for the providers to be able to provide care to the patients. So the actual improvement versus predicted, you'll see our baseline numbers to the far left of the screen, and then you'll see the predicted expectation from Dr. Lee and her team's model in the other column. These were the actual results which we gathered from July 2009 to 2010, And you can see that the numbers were very similar to each other, and the difference is there at the far right side of the screen. So this proved that the model actually worked very well for what we were trying to accomplish. You can see that in phase 1, we had a significant improvement in the length of stay in all our treatment areas, as well as in the new alternative care area or walk-in clinic. And then during phase 2, in September to December 2011, you again see an improvement. And this was after the re-optimization which we had before. So the main treatment areas of our department, the blue zone, red zone, and the PACE treatment area had a reduction in length of stay of 50%. Our trauma length of stay decreased by 18%. And the detention length of stay or length of stay for our prisoners also decreased by 36%. Our 72-hour returns to the emergency department also decreased between 2010 and 2013. And you can see the changes there for our highest severity patients or acuity level 1, 2, and 3. Our 30-day returns to the health system, our 30-day readmissions also decreased for our 4 highest severity levels of patients as well. And you can see the improvements there between 2010 and 2013. So the broad impact of the care is that we improve the timeliness of the care, we improve the efficiency of the care that we were able to provide the patients, we improve the quality of care, which led directly to saving lives and reducing disability for our patients. We improve savings and financial returns for the health system as well. So the improved timeliness of care, we had reduction in overall length of stay of 33% for our patients. For trauma and stroke patients, we reduced the length of stay in the emergency department by 20%. This resulted directly in decreased loss of life and decreased disability for our patients as well. Our average wait time decreased by 70%, which gave us an additional 370,000 hours of gain in productivity, which allowed us to provide care more quickly to the patients who really needed it or the true emergencies. Our return visits to the hospital decreased by 28%, and the number of patients who left without ever seeing a doctor decreased by 30%. Our ED length of stay is significant compared to other similar safety net institutions as well. You see our baseline 2008 at the bottom. You see where we are today, and you see how we compare to other similar institutions throughout the United States. So the improved efficiencies allowed us to increase the volume of patients that we were seeing. So in the ED, exclusive of the trauma patients, we saw a 7.8% increase in the volume of patients that we saw. The number of trauma patients we saw increased by 8.4%, and the number of severe trauma patients, who often arrive by helicopter, where minutes are a matter of life and death, increased by 14%. The savings we had by reducing 32% of our non-urgent ED visits allowed us additional capacity to be able to care for these true emergencies. So we improved outcomes, we shortened the length of stay, patients had more timely treatment and improved access to care. We saved lives, reduced mortality, and reduced disability. We often talk about the golden hour of care for patients. When it comes to patients who are having a stroke, having a heart attack, or who are victims of severe trauma, those first 60 minutes of care that you can provide for that patient in the emergency department, it's documented in the medical literature that decreases mortality, reduces hospital length of stay, and improves outcomes for these patients. So timely diagnosis and treatment of these patients are paramount to preventing future prolonged and expensive treatment and morbidity. It's the difference between a patient being able to return to work and being able to provide for their family, or having to spend their life in a skilled nursing facility receiving ongoing care. So to reduce mortality and disability as well, for our airlifted trauma patients, we saw, like I mentioned, an increase in 14% of patients. With the reduction in the mortality of the trauma patients we saw, we reduced the number of deaths in our department by 56 patients per year. And you can see with a conservative estimate in the reduction of disability of 1%, you can see the number of patients' lives we impacted by being able to improve the care that we were providing and provide it in a more timely fashion.
I was leaving my work at a Atlanta Dream basketball game, and I had friends that were in a band and they were performing. So I went to go see them after work, and I was walking across Piedmont Avenue, and I was struck by a drunk driver. Some people that saw what happened came out, and they called 911. The Grady ambulance came, and I remember going into the emergency room at Grady and my mom and my sister being there, just telling me that everything was going to be okay. My skull had cracked. I had broken my wrist, my thumb, my collarbone, my angel's wing, my back in 4 places. Grady immediately let my family know, step by step, everything, where they were going to take me, what testing they were going to do, why they were going to be needing to do it. They just made it home for them. You hear everything about Grady, and I drive by it all the time, and I never really gave it a second thought, to be honest. But now I do. I think about Grady all the time. I'm Katie Scott, and I'm here because of you. Thank you for everything you did for me and my family.
The life of Katie Scott that we saved and the 55 other lives just like her that we save every year are what the impact of this project is about. In addition, the increased charges and savings that we did by improving processes led to almost an additional $100 million increase in total ED encounter charges per year. We increased our trauma volume and therefore increased trauma encounter charges by $30 million. The new alternative care site was able to bring us in an additional $12.5 million in charges, but more importantly, saved us $21 million in treating patients in the emergency department that we could treat in a lower acuity area. Our savings in revisit penalties resulted in $7.7 million, and the savings in reduced morbidity and mortality saved us hundreds of millions of dollars in ongoing patient care. The additional benefits are these are used in other units, the intensive care unit, the operating room, reduction in hospital-acquired conditions and surgical site infections. In fact, we reduced our infections from post-open heart surgery from 23% to 0% and sustained that for over 20 months. Dr. Lee and her team has also used this in 10 other emergency departments with volumes ranging from 30,000 to 80,000 ED visits per year, and you can see similar improvements in those emergency departments as well. This is also applicable beyond healthcare. The police and the Georgia Aquarium use this to help with crowd control, and this is also used by the Department of Defense. So future improvements with our growing demand, we know that we have to continue to improve. As I mentioned, we're undergoing a facility layout redesign. We're continuing strategic planning and improving regulatory compliance. Super utilizers in our department are still a challenge for us. The top 20 utilizers in our department on a monthly basis have visits of up to 33 visits in 30 days. We're working with our colleagues in case management and mental health to be able to make sure that we get those patients the right care at the right time in the right place. Our new business model in the walking center is what we're going to try and increase the scope of practice for them to be able to actually take care of a higher acuity patient but still with a relatively minor injury. So let's hear a couple words from the Chairman of the Board of Directors, Mr. Pete Carell.
I'm Pete Carell. I'm Chairman of the Board of Grady Memorial Hospital Corporation. In 2008, when we reorganized Grady, formed a 501c3 and brought in an independent, self-perpetuating board, we knew that one of our top priorities had to be to improve the throughput and lower the cost while at the same time improving the quality of the service we were providing. That's where the project between Emory and Georgia Tech came in and was almost the answer to a prayer. I'm the retired CEO of Georgia Pacific and I've run manufacturing facilities my whole career. My graduate education was heavy into operations research, and so this project fit right into my personal sweet spot and the sweet spot of what the hospital needed. The results clearly speak for themselves. The technical expertise that this project has brought to the emergency room, increasing throughputs, improving flows, reducing wait times, all those things are evident and have been key to a lot of what we've accomplished here at Grady. 75 to 80% of our patients enter this hospital through the emergency room, so that is a true bottleneck of the hospital. The project and its results of moving those patients that are less sick through more quickly, to getting people from the door to the doctor more quickly, have been a big success. And as Grady continues to improve, we'll expand those techniques out through the rest of the hospital. And in addition, we're training doctors who have a new skill set, who can go out into the rest of the medical world and implement what they've learned here at Grady. It's been a big home run for all associated. Thank you very much.
So as our presentation has illustrated, operations research has played a significant role and had a meaningful impact at Grady Health System. So to recap, Dr. Atala shared with you the improved efficiencies and improved timeliness of care that occurred through this project that would not have been possible without Dr. Lee's contribution. He also shared with you the improved quality of care that occurred, as well as the savings and financial benefit to the organization. Dr. Lee shared with you the methodology, and I wanted to touch on a very important point here, bullet point number 1. This is the first time in my 30-year career that I've had a model available to me that took into account both the treatment options, the treatment provided, and the disease-specific characteristics that allows then to fine-tune the process around the disease of the patient and the treatment plan of the patient. Everything we've had in this industry prior to now was at a much higher and a much more broad level. This is truly revolutionary for us in our business. And then, of course, we talked about the portability of this project as well, where it has been used and will continue to be used throughout Grady. The fact that it's now present in 10 other hospitals and more are coming online. And I wanted to share with you that the National Academy of Engineering, the Institute of Medicine, have come together on a new project in 2012 around systems approaches for improving health innovation, which is really designed at bringing the healthcare industry into the modern era. You all are used to seeing these tools utilized for years. Healthcare is way behind the curve. I think what you have seen through this presentation is that Grady has been one of the first to use this type of model, this type of advanced model, to really change the way care is practiced, to change the way patients flow through a hospital, and you can see the impact. How often do you hear someone say, this project resulted in 50 additional lives being saved? So in 2008, Grady was undertaking a tremendous financial turnaround. Those efforts were focused first on those areas where costs were extremely high. And at the top of that list was the emergency department. But our quest was about not just saving money. Processes had to be developed and improved with sustainability in mind. They had to contribute to improving not just the bottom line, but also the quality of care being provided, produce better clinical outcomes for our patients, and drastically improve the efficiency with which that care was being provided. We believe that this project accomplished all of that and more. In an era of declining government dollars for public hospitals like Grady, it is incumbent upon us to utilize operations research and analytics to make the best use of the funds that we have. Every dollar we save, every dollar we can earn, every process we can improve helps us meet our charity care mission to provide care to the underserved, the underinsured, and the uninsured of Atlanta. The transformation of our emergency department workflows and the models created in partnership with Dr. Lee are still in place today and continue to be utilized to address inefficiencies across our healthcare system. At Grady, our patients will always come first. Our patients are at the heart of everything we are and at the heart of everything we do. And because of this project's stunning success, they are really the true winners. On behalf of Grady Health System and the thousands of patients who depend on us for life-saving care, thank you for the privilege of being a 2014 Inform's Edelman Award finalist.